itself. I mean, the first thing I want to say is that the purpose really for this presentation was to give an update to most of our NHS colleagues, both working within the hospital and in the community, about some of the things that have been going on in the School of Medicine and the University of Dundee, because there's certainly been in the news a fair amount recently. And I think I've faced a lot of questions, and I've had a lot of staff coming up to me and talking to me about the implications. I think we have been too much in the press for my liking. I think there is a problem with the higher education as a whole, which I'll allude to later on. And about 75% of universities at the moment in the United Kingdom are in financial difficulties. So we are by no means unique within the sector. In fact, we are in the majority of the sector who are currently facing a challenge later on. For those staff who are on the call with the University of Dundee, just please note there has been nothing that I'm going to show that you have not already seen, either within the all-staff meeting, which we had a couple of weeks ago and beforehand, and from the principal's questions time, as well as from the review of what we've done, because I think what I'd like to say right from the start, I'll take the sort of postmodernist literature approach, is to tell you from the outset that I'm convinced that we have a very robust and healthy medical school, actually, that has a long-term future and will continue to generate the type of medical students we have for many, many years, who are of the highest quality and have really added to our international reputation. And that's largely, of course, to the collaborative working between the medical school and our colleagues within NHS Tateside. The actual business model of the medical school is pretty sound and pretty robust and has grown quite significantly over the last few years. But we are, of course, part of a wider university, and within that we have to play our role. But I attended the open day for offer holders just about a week and a half ago, and it was clear to me that some parents in particular and some children were a bit worried about whether, because of the press, whether there was going to be a future medical school. And of course there is. There absolutely is. We've been clear to our students, we've been clear to all of our stakeholders that there is a very strong medical school, and one that will continue for a long time, that will be recruiting and bringing students in 25, 26 and 26, 27 and continue to do what we do. We are a regulated program. It differentiates us from almost every other aspect from the university. We provide something for which there is a critical need, and we're one of the top medical schools in the country. So I think from that, as I said, to get to the end of the story first, is to tell you that I am convinced and strongly convinced that we have a strong and robust medical school. Now I'm going to show you some of the data as to why that is the case. I'll tell you a little bit about all the things that we've done last year, because I'd normally do this at this time of the year. I'll tell you a little bit about the situation of the university itself. And then at the end, if there's any new slides, it's more around where I see some of the future is going to be in terms of medical education generally, because there is a lot of change in this space. But again, this affects all universities and not just the School of Dundee. So now if I go now through the slides itself, let me see if this is actually working now. Fantastic, you can see that. So right from the start, I think what I said I'd talk to you a little bit and update you about some of the issues that we have faced within the higher education sector. And I think it's useful for all of you, all of our colleagues in the NHS and the community to be aware of that. And this information was presented by the interim principal on the 11th of March in 2025 to the whole university, and has been shared by the school. So there is, of course, both within England and in Scotland and in all four nations, a general structural underfunding of higher education. And I think you've probably all have read about that in the papers. That situation is not great in England, where the current fee structure does not pay for the average student to go through university. It now costs more to deliver than the students are actually paying. And of course, you can imagine in Scotland, that situation is even worse, because England get about £9,500 per student, and we get just over 6,000 in Scotland. So again, as costs of delivery and of estates and of fuels and salaries have all gone up, the cost of delivering a free education, while there have been great benefits in terms of widening participation, as such that the higher education in Scotland is just struggling. It just cannot really cope with this anymore. Now, to some extent, we have managed that in the last few years through international students, because international students bring in high fees, and those high fees then cross-subsidize the teaching of Scottish students. And then what happened was the United Kingdom as a whole brought in these visa regulation changes, particularly around bringing families. And that has led to a massive downturn, about a 30 to 40% reduction across the UK, with some areas affected more than others in terms of international student fees. So that's like you've taken your one source of major income and you've just halved it. And that has had a devastating effect on higher education. Now, there were some issues undoubtedly around international students. There were some ways in which the system was being gamed, and that had to be addressed. But I think this approach taken by UK government has been a mistake, and we've all seriously suffered from that. So within that, of course, there are these inflationary pressures and national insurance costs, which I think many of you in primary care certainly recognise, and I'm sure within the hospital, that have affected us as an institution and added a few million to our costs for the year. And then there's a chronic problem of underfunding of research. Research is fundamental to what we are as a university and what differentiates ourselves from colleges. On the other hand, it is just not funded. And again, this is a long-term problem that the UK has to address. Now, when I was in the States, and as many of you know, I did a lot of my research training in America. At Yale University, where I was based, Yale took 66% of my research income. So 66% of what are called indirect costs went to the university. Now, Elon Musk, as you know, is going through and trying to get rid of everything within the States to do with that funding and thinks this is excessive. And in this case, he's probably right. It is excessive. But in the UK, if we say take the major funder, which is UKRI, they will pay 20% indirect costs, but only 80% of the direct costs. So ultimately, the indirect costs, the pensions, the salaries, the estates, all have to be paid for by the university. The argument from UKRI is that government gives money research funding for science, and certainly they do so. In England, that figure has gone up about 75% in the last 5 to 6 years, and Scotland hasn't really gone up at all. So again, there is chronic underfunding of research, and we're having to cope with all of that. The interim principal also highlighted some institution-specific problems. We had a budget that was based on continuing growth, and what we've now seen, of course, is that growth was never going to happen. We didn't pay enough attention to cash position, which is why Dundee is different. If you think about Dundee's, cash deficit, which we've talked about, the 35 million, well, Edinburgh's 140 million, which dwarfs us in comparison, but their cash position is stronger. And Aberdeen and Robert Gordon University have gone through this. Glasgow University is doing a recruitment freeze. St Andrews is doing the same thing. All universities in trouble, but they slightly differ in terms of their cash position. There were undoubtedly some poor investment decisions being made, particularly in the IT area, which those of us in the university know about. The next line you'll see there are blueprints. In the NHS, you won't know what this is, but this is to do with how we process applications. And this was an unmitigated disaster, to say the least. And as such, it meant that we were struggling to recruit people at the worst possible time. And then in the background, we've had a growing structural deficit over a number of years because we are a very research-intensive university. And I think without then having sufficient growth in terms of education or teaching, it was always going to be a struggle for us to maintain that. So as I've said, I think it's critical we maintain research. I think it's critical we maintain enterprise, but we need to think very much about what we are like as a university now in order to achieve it. Because unlike the NHS, frankly, when we reach a budget deficit, we've got to figure out how to address it because we're much more of a business with about 25% of our funding coming from Scottish Funding Council. If the NHS runs into financial problem, it just carries it over to the next year, as you know, and sometimes government come in to affect it. So we don't have that. And so what we're looking at is what is the size of the university going to be going? How do we reshape and rebalance so that we can deliver education, research, and enterprise in a way that is affordable in the longer term? And that's led to some debate around the restructuring of academic and professional services. And I'm not going to go too much to detail. This is what was proposed a while ago, but there is a consultation going on, Price. They talked about a faculty system in order to drive efficiency. And there are arguments absolutely for this and absolutely against it. And within the medical school, we've had a big discussion about this. And we have collated various ideas about how we might do things differently, both in terms of what a faculty would look like, or even if we go to a faculty. And that consultation is going to go back to our university senate, as well as to the university executive group. And I very much believe that they will look at this, I hope they will look at this, and consider some of the thoughts that we've come up in medicine and every other branch of the university have also thought about. But how can I also be how can I be so secure? Apart from the medical school, which I think no matter what size, shape or form it took, was always going to be robust in terms of what it did. For the university as a whole, of which we are a part and which plays such an integral part to the lives of people in Dundee. If you think about it, the university and the hospital are two of the major employers, and so they really are fundamentally important. Well, I think what you've seen in the last few weeks is now massive government input. So you will have seen, first of all, the most important statement came from the First Minister, John Swinney, when in response to a question from Michael Mara, who's one of our local MPs, there is a secure future for Dundee, and I want students to accept their offers, be confident of his future. So that's a really important statement, which I am certainly sharing with every single student who looks at the School of Medicine, just to say, look, it's clear we are here, and we are going to be continuing in 25, 26 and beyond. An expert group is being convened, led by Alan Langlands, who used to be the principal in Dundee. He actually left in 2009, took another fairly senior strategic roles, and he'll be working with a few other colleagues in order to try and provide the interim principal and university executive group with their thoughts about what the university should look like and its shape and how it's going to respond to these challenges going forward. So it's an advisory group brought in by government, and you can see Jenny Gilruth and Kate Forbes, probably you picked up in the news, are all going to be involved in this process. So again, there is shared interest nationally to the ongoing sustainability of the University of Dundee. And I think we've got to take that, I think, as a real positive about not just the reputation and the contribution we've made over the years, but the value in which the university, not just the medical school, is held by the rest of the country and by Parliament. So why are we are? And so now I think, let's put that to bed, because we're going forward, and let's now think about and what we have to be proud of, because what we do so incredibly well in a place, we are a small city, 150,000, and yet we have always had such a wide impact from the work that we do, and our reputation is strong. So why, and why is that? Well, as you can see in these typical league tables and guidelines, but we were at the top medical school in Scotland. I mean, I think that in itself tells you why we should be sustained. Second in the UK in medicine for the Sunday Times in University Guide. There are multiple league tables, but bottom line is that we're highly ranked in all of them. Joint top in the UK for graduate prospects, world top 200 for medical schools, of all the medical schools in the world in the top 200, and within the university, by far and away, I think one of the most prestigious schools, ourselves and probably life sciences in terms of our international rankings. But we were also ranked highly in a 5-star rating for our undergraduate clinical program, the MBCHB program, which is, again, it's why testament to all of our colleagues, not just our own staff and academic and professional services staff, but our NHS colleagues, because we are ranked as a 5-star MBCHB program. And that's why we're so highly ranked around the world. So what do we do? What other things happened in 2024? And we've tried to make some changes over the last year, which I think is useful just to give you an update on. The first is we've always talked about doctors from day one. That is what made Dundee unique. We didn't do a sort of classical 3 years biochemistry, pathology, bacteriology, non-clinical undergraduate program before moving to the clinical. It's very much always been about doctors from day one. But that got hit in COVID. And I don't think we were really doing as much doctors from day one as we should do. But working with our local DMEs, I think we've managed to make a big change within this place. And we're now introducing more bedside teaching in year 1 to year 3. And Sarah Alison Redfern is going to be leading on that, collaborating again closely with our colleagues in the DME department. We're also looking a bit more at the development of community-focused patient journey in year 1s to 3, led by Dr. Sireen Khan. And Yvonne Wedekin is leading on a drive for new patient volunteers, which again are a critical part of our program. So it's really good to see that, because I think we've got to get really back to that idea that we've got a very clinical, very much doctors from day one driven type program in Dundee. It's what makes us distinctive. Now, the other thing we introduced last year, and we were one of the forerunners in this process, was the medical licensing assessment. For those of you who are not aware of this, now every medical student in the country sits the same exam at the same time in the year. And this is a major achievement. And I think all hats out off to the MBCHB team, academic professional services, because there was both an IT failure and 2 fire alarms during our first MLA assessment. I mean, you couldn't make it up. It couldn't have had more challenges, and yet they handled it well. And the students were absolutely brilliant and rode it through, and our results were fantastic. And we were, again, amongst the top in the country in terms of our outcomes of the MLA. So something to be aware of, because all schools will do it. Sadly, what it means is that someone somewhere is going to do a ranking system based on MLA. And as we try and create lifelong learners, as we try to get people thinking a bit more about medical education, or students in particular, what we're increasingly going to see, of course, is, well, what's in the MLA, and teach me to that. And if it's not in that, I don't want to know it. And that's one of the challenges, and always been a challenge in medical education, and the MLA may work that worse. We've looked at our assessment and spent a lot of time looking at that, getting better question tags, looking from what the OSCE examiners are saying, looking at our student feedback, looking at our curriculum content to make sure that we've actually got questions that are appropriate and relevant to the different stages of someone's education, develop much stronger relationships with the student body through better communications and more frequent assessment. And we're trying to look at our operational efficiencies, improving them. We are aware that not only are the university challenged, but so is the NHS for time. And I think we need to be doing things in a much more efficient and much less labor-intensive way to try and ensure that if we're going to assess, it's important assessment that's of value and is critical, and it gets feedback rather than just assessing everything. And we've got to think about how we deliver things in a way that achieve what we want to achieve without actually taking a huge amount of time, sometimes where the effort actually is not worth the outcome that comes through. And we can all talk about admissions and various other processes in that. If we look at the NSS, which is the National Student Survey, which has gone on, again, the team have done great here. Many congratulations to them, but we've done far better. And if you look at every single outcome measure, not only have we improved from 2023 to 2024, but we are above the benchmark value in terms of the quality of our teaching, the intellectual stimulation, of course, and challenging, etc. But most important is the quality of the teaching. And I think it's really good to see that. And we should get the 2025 results soon. And I hope they continue to show this sort of positive trajectory. Number of new appointments on the course. Just to know, I mentioned Sarah Alison Redfern about the early patient contract, Kirsty Brown taking over as OSCE lead, Cindy Chu as clinical reasoning lead, and Tom is chairing the professionals committee as we go forward itself. We started this year, you may not be aware, of a Gateway to Medicine program. So this is a program where we take students mostly from widened participation background. They get modules in life sciences, anatomy, healthcare, clinical skills, and they go straight into year one of the curriculum. And this has been fantastic this year. We've run it ourselves for the first time. We've got 25 home students from Scotland, all of them doing really well. This Rob Jarvis is leading this program, and it's really good to see the work that is happening there, which will really help the widened participation agenda in Scotland. And actually this year we also took 5 Afghani women into the program, and this may be something that continues again in the future, but it's really a huge change for them, a language change, a culture change, but a really positive development for the Gateway program. There are a number of other innovative projects which have happened. Some of you may or may not have been involved with it. A new pharmacy contract for delivering the teaching, the first teal cadaverific laser enucleation of the prostate. That's a course of that, first in the world. Palestinian summer school happened last year, which David Russell set up, and I think was really good to see in place. We're looking at new types of simulation exercises, an area which I think is going to develop, and a new high-tech mannequin called Leonardo brought into the centre. We've done a lot of work in student support. I think all of you recognise, and I think all of you see, that a real change in every generation, and mental health is a big thing about the generation coming through now. So a lot of work going into that in terms of what we are offering and how we are helping students, wellbeing passports developed, looking very closely at how we can develop disability needs, and thinking about how our best practice and inclusive teaching to support students coming through. Therapettes came in for the first time this year. Some beautiful dogs brought in to help with the students. And again, you're beginning to see this sort of thing happening all around the country, and it's always useful. And there's been some music. Many of you will have noticed the band came in, but many of you will have heard the piano in the main area of the medical school. And yeah, sometimes it's brilliant, sometimes maybe not quite so good, but generally it's great to see it, and it's just adding a little bit and a bit of variety into the program itself. And we will continue these sort of things throughout the year. And for staff, of course, Pilates and other activities, the things we can sort of do, and I actually wish that we did far more within the NHS as well, in terms of how we support staff within that space. You may not also be aware, but this year, for the first time, we introduced inaugural professorial lectures. There used to be what are called Discovery Days, which were held on City Campus, where everyone gave a 5-minute lecture to the public. This year, we decided, and the university decided, to make more of a song and dance about this. So we had big presentations, which were really good, actually. Ellie Hothersall-Davis, who many of you know, who ran the MBCHP program, is now head of undergraduate, been involved in the medical curriculum as well as the public health department for many, many years, particularly in teaching and assessment, gave her inaugural professorial lecture, and Adrian Soren, who's done some really great work in cancer research, and gave if you wanted to see how someone talks science to the general public, Adrian's presentation was fantastic, and I'm hoping he can come and talk to you at one of the grand rounds in the future, as well as Ellie talking about medical education, because I think these are worth seeing. Some of the divisional highlights, well, this has been well, there are many years of respiratory disease, but this has been one of the really big years for the respiratory department, led by James Chalmers, working along with Amelia Schumacher and others. But this was one of the things we've done here, and this is a complex slide, but suffice to say that after over a decade of basic science research, James's group have come up with the world's first therapy for bronchiectasis based upon their work, and I think that was a huge triumph. It'll be a huge impact case for Dundee, and many congratulations to that team. James has also brought in funding from what's called LifeArc, and this is collaborative research designed to understand rare respiratory diseases. And again, he'll work closely with Amelia Schumacher in this area. And some of James's fellows, like Merritt Long, have had some really successful publications working with that group within all of these specific areas. The respiratory team will know about this, but I just shows you the impact. If you look at these journals, you can see how far-reaching and great the impact is going to be from this work. And he's also developed the EMBARK project. Again, we're big about health, electronic health record data and bioresources within Dundee. It's something we've done well over many years. And EMBARK has now exploded around Europe and into China. And this is going to generate a huge amount of data, I think, which will for better understanding of disease and being better able to develop new therapies within this space through linking multiple groups around the world. And then, of course, for the local economy, James hosted the world's first bronchiectasis conference within Dundee. And as James notes, that brought in over £1 million to the local economy in hotel fees and in people eating out, etc. And I think the more we can do of this, using some of the great resources we have, like the VNA and other areas, I think the better it is for Dundee locally. MEMO, the Medicines Monitoring Unit, continues to do their research with a big focus on decentralized clinical trials and pharmacoepidemiology. I think to add to that, you may not be aware of this, but with our colleagues in the NHS now, we're developing the first NHS genetics department that's going to be using pharmacogenetics, for instance, in predicting responses to clopidogrel post-stroke, and that'll be the first within the UK. We're also increasingly looking at decentralized clinical trials. I mean, all of us now wear some form of monitor on our wrist, and that allows us to look at heart rate, blood pressure, oxygen sats. And with our phone, people can feedback on apps. You can do digital consent. So we can start to run clinical trials now at a fraction of the cost of the major clinical trials in the past, and actually try and look at a much wider cohort. And I think this is a very, very much a future area where we need to drive going forward in all areas of research within the hospital. One of their key outcomes was a fabulous little paper that came out, really looking at, this was from Filippo Pigazzini, who's in the school, from the MEMO group, who was looking at the effect of morning versus evening dosing. And they had done the time study, which essentially showed that overall, whether you took your blood pressure medication in the morning or in the evening didn't make any difference. However, if you're a morning person, I'm a morning person, I become useless after about 8 p.m. in the evening. But if you're a morning person and take your medication in the morning, your outcomes are very much more positive. And if you're an evening person, you take your medications in the evening, your outcomes are very much more positive than if you do the converse. So if I'm a morning person, taking my tablets in the evening is a no-no. My outcomes are actually worse than average. So fascinating, simple study, which I think has got people now, again, once more interested in prototype biology. And I expect to see more information coming out about that in the future. In the basic science place, we continue to do basic science research, very much focused on human-related research. This is the work from Colin Murdoch and his team on creating a placenta on a chip, which is a 3D organic technology which allows you to look at to test new therapies, understand signaling better in more replicative systems of human disease rather than single cell lines. And I think I envisage we see much more of that work. And some of our leaders, like Sourav Banerjee, was honored as an emerging leader for his work in cancer. And in fact, some of Sourav's work, particularly glioblastoma, I think is quite fascinating. And I think he, again, is developing novel drugs, some of the first drugs ever to be brain penetrant and have the potential to make a big impact on this disease. Mark Baxter, who was just started as a clinical academic, clinical senior lecturer. You see, there are people coming into medical school. And he did the first comprehensive assessment of a very rare condition, which is cancer during pregnancy. And again, important data for the population to know about. And Samira, and sorry I've muted her, but Samira is one of the first big projects with pharma, with AstraZeneca, looking at new chronic kidney disease research, something which has, as you can see, has a major impact on people's lives. And Samira, who has now become lead for the Dundee Clinical Academic Program as well, doing great work within the space of renal medicine. And one of our newer appointments in gastroenterology, Richard Hansen, worked with Archie Foundation to start a new lab in gastroenterology, in pediatric gastroenterology, looking at the microbiome. And it's great to see this academic pediatric gastroenterology progressing now. And then we have, of course, again, the quality of the work and the output, the most highly cited researchers of the world. And we've got two of them, in Blair Smith and Albena Dinkova-Kostova. So again, fantastic work that these people are doing. In the postgraduate space, continues to be a lot of activity, and I'm just highlighting one here, but there's been a huge amount of activity in this place, and that is because the Centre of Medical Education now prepares for 6,000 graduates. I think set up in 1972, now 6,000 people come through, did their medical education certificate in Dundee, whether it's diploma or master's or whatever, and I think, again, that's part of our reputation and the impact we have on medication throughout the country itself. Within research and innovation, which is, as you know, is currently led by Russell Petty, which is our led through TASK, which is obviously the joint collaboration between NHS Tayside and with the University of Dundee. We've got about 450 active clinical trials, 134 where we're testing CTIMPs, where we're testing new drugs. 82 new research projects, nearly 5,000 patients recruited in 2024, which makes us one of the best in the country after Lothian in terms of the number of people who are participating in clinical trials. We've got the fastest time, even though it seems to take a long time, we're actually the fastest in the UK for setting up these new trials. And I think this is an area I've asked, certainly my clinical academic staff, to really deliver on. I think this is important. It's really important for the people of Dundee because drugs are expensive. I mean, I'm a diabetologist at the moment, figuring out how on earth do we try and legislate the use of Mounjaro and other of the new GLP-1 receptor agonists, which, you know, at the moment, I think of 1 million prescriptions across the UK in GLP-1 receptor agonist or Mounjaro, 2,000 come from the NHS. The vast majority are private. So there are ways in which we can give therapies which are actually going to benefit our patients. It's going to benefit the health board of not paying for it. I've just used Mounjaro, but cancer is another one where we're saving hundreds of thousands of pounds to the university. And so I think as to the hospital, I think we need to be getting people into clinical trials when we think they're appropriate, as often as we can. And here's an example of the first personalized cancer therapy for gastroesophageal cancer. This is a cancer vaccine. I think this is amazing stuff, actually, and it's part of the future of cancer research, where they will take a biopsy of the individual who has cancer, like a biopsy of their tissue. They will basically create a vaccine targeting against maybe 15 to 20 of the epitopes on that tissue itself, and create a specific vaccine for dealing with recurrence and metastases. And I think the results are looking really impressive. Now, what a world is that, where we're individually vaccinating against cancer? And it's so exciting to see that happening, and that we're leading on that way in this context with gastroesophageal cancer, but hopefully in other areas too in the future. Taymed Connect is now fitted as part of the refurbishment from the Tay Cities deal. Within that area, we imagine we'll put one of our med tech space. Our health informatics core has also gone in there, so we'll see a lot of the data and digital health we see developing in that space. If you get an opportunity, I think there are great facilities, particularly. If someone could put off their phone, that would be great in the background.
Yeah. Like,
If you can mute them.
Zoom meeting.
And then finally, of course, we joined in the Nine Wells celebration, 9 Wells at 50, and I guess you all have seen that tiny wee cake that was present in the foyer staff to see going by. But again, it's part of our collaboration, and being based within the hospital is one of the great selling points of Dundee. We've focused a lot over the last few years on school culture and social responsibility, and that is are we town and gown, the traditional view of the university, or are we part of the community? And I think we all know that we are part of the community in Dundee. And so what I've been keen to really push is this idea that actually we should be taking part in things, some charity work, for instance, in Togs or the Nine Wells Community Garden, and staff are allowed, a couple of days a year at least off from their work where they go in and help. And it's been good to see people volunteering for this. I think that picture also tells 1,000 words, because in general it's women that volunteer and men don't. Well, I've got to say, I've been out and I've done all of these, but I think it's something that I'd like to see us working on more. I think it's a really important part of what we do as a university. We get out, we meet people who are doing fantastic work and contribute to our society, not just sit here in our ivory tower doing our research and working away. And of course, many of you I know in the NHS do that as well. You're working in community, and you're based in the community, working in the community, and doing other things locally. And other people, of course, volunteer in other areas, and great for them. We've had the Margaret Fairley lecture from Kim Graham, a great lecture highlighting the super work that women have done in science. And they had the Yanti Dasaga lecture looking again at the whole issue of racial equality and diversity and what we need to be doing within different medical schools, and highlighting again the work that's happening in terms of our race working group and Athena Swan committee. Now, medical education in Dundee and beyond. And I said at the end, and I know I've raced through some of these slides, but I thought at the end I'd talk about some of the challenges that we're now developing, because medicine's changing all the time. And I often, when I walk around on the wards, of course, and I talk to colleagues, and they say, well, it's not like in my day, we did A, we did B. And it's one of the challenges of medical education programming is that it constantly has to evolve, because the needs change. The needs of the community change, our understanding of disease changes. But of course, we are a heavily regulated body, and the GMC changes all the time, and it responds to changes within society, as you all know. And that means that we have to adapt our curriculum. And one of the hardest things to do when you're adapting a curriculum, you take a very, very full curriculum, and how do you put more things in it? Because you've got to then take some things out. And I think that has an impact, but it continually evolves. That's both its excitement, but also its challenge. And why I think, of course, we have to eventually move to this idea, or we should be moving to this idea of lifelong learning, because when you graduate, it doesn't finish. It's really just starting, frankly. And it's just making sure that we inculcate this culture of lifelong learning and reflective and critical practice, which I think is so important to us. And again, GMC want us to do this, and at the same time then introduce an MLA, which tends to make our teaching more restrictive. That's life. In Britain, can't get out of assessment. It seems to be something that dominates our lives. And right, we examine 5-year-olds at school, don't we? And I think there's lots of things that we perhaps need to do as a society. We are limited in what we can do. So prediction is difficult, especially about the future. And so how do we get that quality, independent, critical thinker who is going to continue to learn and not just accept what they read and what they understand, and continue to develop as a clinician in the future? And that's what we want from medical students today. They've got to be the doctors of tomorrow. So they've got to carry our values and our skills and what we think the profession might look for. And we've got to think about the fact that there's an increasing expense of healthcare. There are loads of fantastic new drugs out there, all of which are incredibly expensive. And so how do we manage that without taxing ourselves at 70%? And that's something we all discuss in the NHS as a future. Do we need, though, as physicians and as healthcare professionals generally, to be far more aware of the costs of healthcare and how we are able to deliver that effectively? We can't just stamp our feet and say, I must have this hip prosthesis, or I must have this drug for my cancer, when we can't effectively afford it as a society. So how and when do we make those decisions, and how do we do that at both a local level or as a national level? So we need our students to understand this a little bit more. Care is increasingly fragmented between primary and secondary care, less so in Scotland, but much more so in England. And I think we need to address that. And where is care best placed? Again, I think we have a very secondary care focused education. We have a very secondary care focused funding model. And yet the reality, most diseases in primary care and most early diagnostics are going to be in primary care. And if I were talking to a student now, I would actually say the future is in primary care. I think with AI and early diagnostics and imaging that can be done in the community, you can do a huge amount of primary care that never needs to get to secondary care itself. And that actually prevents people coming into hospital. So it's talking about health versus health care. And ultimately, that must be the way that things go, as well, of course, as societal messaging about what is healthy and what is not healthy, and not being afraid to address some of the challenges that we have in society, which I don't think politicians do address and should address. We have an aging population, as you all know. The demographic is changing hugely, and as people live longer but actually develop, but longevity is increased, but healthy lifespan is not necessarily increased, and there are more needs and more drugs. Well, how do we manage that better, again, within the community? But we have a demographic that's changing, not within the aging. We also have a diminishing workforce, not just because people aren't wanting necessarily to go into a medical career, but because we have fewer kids coming through. The number of 18 to 20-year-olds is falling every year. And so we're recruiting in a much more competitive market. And we probably cannot have this very doctor-centric care model anymore. We're just never going to be able to train enough. So there's community and there's value-based healthcare, and of course, rapidly exchanging and expanding knowledge. I mean, we're all now, I'm sure, at that situation where we're used to people coming in, having read on Google that they have X, Y, and Z. And we need to figure out how to deal with that. And how do we deal with AI, which is going to, as something that helps with practice rather than gets in the way of practice. So this is a complex area that we have to try and start to get students thinking about. So medical education has to adapt rapidly. It's lifelong learning. It's a move to generalism. Let's get, I think, again, real. The last 30 years have seen a push towards specialism in all the different specialities, and yet 80% of Ninewells is full of people over the age of 75 with multi-morbidity, right? So we need generalism far more than we need professionalism. And a lot can be done within that specialist space by people who are not doctors. And I do think that that's going to change. We need multi-professional training, because what does that community of practice look like? And how do we get our students to be trained within that environment? But we also have a student body who are far more interested in work-life balance than certainly my generation was. And we have to, and they're probably right. And so we've got to figure out, if we all move to a 4-day working week, how do we accommodate that in terms of delivering the care that we do? We've got to recognize portfolio careers. I remember going to my son who actually did economics and finance. And his dean in Aberdeen, standing up and talking to him, you were going to have at least 5 or 6 different careers in your life. Now, in medicine, we never thought that would be the case, but actually, it is going to be the case. And we're going to see people coming in and coming out of different careers at different points in their life. They want to have a look at work-life balance. They want to think flexibly. We have to deal with diversity and many other things. So there's also an unprecedented and growing demand for healthcare. There's more remote and rural healthcare, but at the same time, people don't want to live in the remote and rural areas, certainly not people of the younger generation, and all people who retired from the city. So how do we deliver that care, and how do we do things differently? And then finally, at the bottom there, we have a far more informed public. And again, so we need to have doctors who can communicate that and can engage with the public better perhaps than they have in the past, because they can't just say, because I said so anymore. I think there's got to be a much closer conversation going on. So in terms of the medical understanding curriculum, these are our 3 major outcomes: professional values and behaviors, professional skills, and professional knowledge. The last bit's easy. It's now called the MLA. We have to develop our curriculum around that. We have to blueprint our assessment and exams and our teaching modules around that, so that the students are able to pass that exam, because that's going to be their focus, and it should be our focus. We want everybody at the end of 4th year passing that exam. Why do I think we'll do it? Well, I think Dundee's got a fantastic history in medical education. It's been our strength for an awful long time. We've got a great history of innovation in medical education, right back to the spiral curriculum. And as I alluded to earlier on, I think we've got to move a little bit more back towards that spiral curriculum, because I don't think we're quite as spiral as perhaps we were when it first happened. We've got to think very much, and I'd ask my colleagues on the call to think very much about what they are teaching students. What is really important to learn in cardiology in year 2 and year 3? What are the essential bits in diabetes and endocrine? Because I think we probably ask too much. We force in too much education, which is not necessarily needed. Is what is needed at each stage in the career. I remember sitting down once with a physiologist, actually, in a conference, and he said to me that he felt his role was to teach the sort of physiology that a medical student would need to have for the rest of their life. So they had one block with a massive amount of information in it. So you know what's going to happen there. The student is going to memorize that information enough to pass an exam with 1 mark over the pass mark being a wasted mark type attitude. And then 2 weeks later, they've probably forgotten all they do about physiology. And 3 years later, they can't recall it at all. So again, it's about thinking about lifelong learning, about trying to provide this information throughout the 5 years of someone's education, continuing reinforcements. I don't think you devalue the basic science, but you continue to reinforce it all the way through, and then try and inculcate this so that later on in the postgraduate space, they're continuing to learn this as well. And sadly, I don't think in the postgraduate space they do. I think postgraduate at the moment is less about education than about service. And unless we address that, we're going to see more and more doctors on the plane to Australia and New Zealand, because why would they stay in the UK when we don't really educate them in the postgraduate space? So I think there's a lot to do where we've got to link closely with our colleagues in the Department of Medical, in the DMEs, to try and ensure that in the postgraduate space, we're also valuing continuing that education journey. In terms of the type of approaches we're going to take, I think technology is going to really become dominant. We have led the way in simulation-based training, and I think we're going to see a huge amount more of that. And it's what this generation predicts. For those of you who lecture on our program, please don't give a 40-minute or 45-minute lecture. Nobody listens or pays any attention beyond 15 to 20 minutes. And so we now need to be thinking very much about what we deliver. We need to keep them to 15 to 20-minute chunks, with then some form of engagement and critical assessment afterwards. But we'll do much more simulation-based training, both virtual and augmented reality. Gamification is being brought in. Social media can be used as a tool. Tutorials are on. I don't think we use tweeting anymore. That's a no-no. Tweeting or X, we'll go off that. We'll think of something else. Online journal clubs, flipped classrooms, digital learning platforms, personalized education with micro-learning modules that people can dip in and dip out of. We've got to be slightly careful there. Because I still think people have got to be here. They've got to be on site, and we're not open university. So I still expect students to be in, and I expect staff to be in, and I expect them to be engaging. And I would like feedback from our NHS colleagues delivering lectures, because students are not turning up, or they're wandering in late, or they're wandering out early. Then I think we need to know about it, because I don't think we should tolerate that. They need to also learn about artificial intelligence. We need to address widening anticipation and people who start out from a different baseline at the start of medical school. How can we develop networks? That might be a way of addressing some of our remote and rural issues. And how can we collaborate with different groups in terms of the type of education we offer? We've developed the MBCHB Moodle, which is an online learning platform with more flexible tools, returning feedback and developing interactive learning. And I think that's a good way for students to work on. And obviously, we continually review its content and structure, as well as the type of feedback. Again, feedback has got to be useful. Having feedback after every single lecture and every single session, I think, is useless, right? It's like getting every time you buy something online and you have to feedback on the salesperson. I think you just forget about it and you ignore it. I think feedback and assessment has to be useful and beneficial. It has to be quick. No matter what your response is, your feedback has to be quick. If you wait 2 weeks, your feedback is wasted. It's not going to help. It's got to be very, very quick. And we've got to look at how we can make that easier for staff to be able to do. Simulation I've talked about. I think the evidence is really strong for simulation now. Again, if you have the opportunity, and poor old Neil and Jill Keith and others will shout at me, but if you look at clinical skills and if you look at surgical skills, some of the stuff down there is absolutely fantastic. And I think it's really great to see that coming in, and the students love it. And I think it's very valuable. Not for everything, of course. There are some things you have to see in real world and at the bedside, but it can actually help people get there. And we need to embed that in both the undergraduate, but also in the postgraduate curriculum for our trainees. This is just an example of the 3D center. And again, if you've seen this, when you actually it's almost 4-dimensional, because of course you can have the smells and noises coming out within speakerphones by the side. You can have the traffic going past and everything else. And it suddenly creates a scene that, even if it's a mannequin, is so much more stress inducing. And you realize what it's actually like to be there. And this is just great training for people. You can simulate hospital wards, bedside settings, and many other things. And again, here we've got an entire ward now set up, so we can now do multi-professional learning, working with our nursing colleagues, physios, OTs, surgical teams in different areas, bringing them all in together to see how you manage and best manage complex cases or situations as they recur. And I think, again, this is hugely important going forward. Now, what about then the last part of the curriculum, which is around professional values and behaviors and professional skills? How do you actually assess that, and what is it we want to achieve? And this is where I think we can give a more distinctive flavor. Because the MLA, we can't really give a flavor. It is what it is, and we can teach to it. But this aspect around professional values and behaviors and skills is something that we can give a unique Dundee twist. And we were in many respects ahead of the game with this. Many of you will have been involved in this curriculum review that happened a few years ago, which had multiple stakeholder involvement, people from across the medical school, from across NHS Tayside, members of the public, people from different faculties within university, all getting involved, talking about what is it you wanted to see the doctor of tomorrow developing. And we developed through that, not just the idea of educational continuity throughout the 5 years of the program into the postgraduate space, but also the idea of the Dundee doctor and the bigger picture. And so what do we mean by the Dundee doctor? We're effectively someone who has the skills and knowledge and compassion that we want to see within clinicians, wants to make a positive impact, wants to be a decision maker, in no matter what branch of medicine they choose to work in, and also wants to then advocate. So team working, learner, teacher, leader, innovator, advocate, physician, decision maker. And of course, not everybody is going to do all of those things, but it's trying to give people an exposure to all this, or students an exposure to these different aspects of what we all do, I think, as healthcare professionals. And how do we do that? We do that through seminars, reflective practice, our student-selected components, some self-directed study, which I think is actually important, looking at professional identity and talking about that, some of our core teaching, and of course, some of the volunteering work. In terms of leadership, we're not just talking about leadership, we're talking about entrepreneurship. We now teach it, and through the Centre for Entrepreneurship, we have prizes every year. And this year, in fact, there were some fantastic prizes. There was a group of students who came together who developed a new AI system for looking at OSCE examinations. We had a student who came up with a project where you, with basically a device that goes in the toilet that detects glucose, so that we might early detection of diabetes. It was a great skill, actually. And another student who developed a new device for treating severe allergic reactions quicker. So again, some great entrepreneurship. And some students, we hope, will do that. They'll go out to become the business leaders of the world. They won't necessarily work within the healthcare system, but they will be helping drive and innovate within healthcare itself. We've got to talk about artificial intelligence because it's going to be part of their lives, robotics, how to deal with complaints, how to deal with social media, which is so important, their own media skills in terms of how they present themselves, talking about healthcare systems and how they interact, and how you might use design principles to change the way you do healthcare, and how to communicate risk. In terms of healthcare improvement, we want really all students to have done healthcare improvement projects during their curriculum time. And that's really talking about taking an issue and trying to make a difference and trying to see whether you can improve things and closing that classic audit loop. But again, something that perhaps was devalued by the way we went about audit, but actually is really important. And last year, you'll have heard about some of the changes, for instance, to asthma inhalers and around sustainability that came through this whole process. And again, I think this is really important, and it's just driving a different aspect of medical care. We have now established the integrative teacher, and I think this has worked really well through years 1 to 3 and years 4. And this is bringing primary care much more closer into secondary care hospitals. Small groups, reflective learning, talking about professional values of behavior around cases, largely driven by our primary care colleagues. And I think there's been a really positive aspect of the course. The students love it. They really think it helps. And again, it's just getting in that whole doctors from day one, how are you professional right from early on in your curriculum. And then, of course, we develop a portfolio. This is roughly what it might look from year 1 to year 5, how we start to pick up on that sort of Dundee doctor bit in terms of, early on tutor reviews, later on clinical reviews, and trying to use these SSCs in a better way for the students itself. Students also are going to have to look at social purpose. I talked a little bit about what we're doing with staff, but we're also doing with the students who have 4-week modules of community engagement, working with the third sector, working locally in Dundee with different charity groups, looking at health inequalities. And I think this type of thing is really important and will be important to them as future professionals, where over 50%, as you know, are going to work within the community. And even those who aren't need to understand about health inequalities to deliver best care within secondary care itself. Because these sadly have got worse, and health and wealth inequalities in the UK, as many of you know, have got worse in the last 20 to 30 years, not better. So how do we address some of these challenges? Well, we need to talk about how moving towards team-based education rather than just individual education, We need to talk about guidelines and evidence-based practice. I think we need to talk about partnership working with patients rather than sort of paternalistic approach. And most of us already recognize that and do that. We need to talk about lifelong learning as opposed to just memorizing and telephone book learning, which I think has dominated medical schools for a long time. Trying to recognize that the knowledge is out there now through Google and other sites, and we have to understand that. Sometimes patient expectation is unrealistic. So how do we address that? How do we help them interpret complex information and tell them that a sore throat doesn't mean that they've got esophageal cancer or some other situation like that? I think we need to ensure we talk about generalism. I talked about multi-morbidity and polypharmacy. I think it's really important that we address this for everybody and we don't become too specialist-based within secondary care. And we have these longitudinal clerkships, which I think are great. They work mostly through the ScotGen program, where people can spend up to a year in one primary care and follow patients throughout their journey. But we'll try and embed this more within the Dundee curriculum as well. And finally, we've got to bring in data science. And I won't go into more detail about that, but we do need to bring data science. It's there, it's everywhere now. We need to understand about data governance, health informatics, some of the ethical and legal considerations. What do we do with personal health records? How do we use AI in this context? Digital diagnostics that are coming in, and of course, precision medicine. So this is a core part of the competencies now developing and training. I'm keen we bring in more research. Again, it's a period of critical thinking, and we're looking at these through the SSCs. And of course, later on in life, you have MD, PhDs, clinical lecturers, primary care, secondary care. And that is not just research, actually. I should really say research and teaching, because I think we need to have a clearer path of teaching as well, from lecturer to senior lecturer and above. We have it, and you may not be aware of this, but the number of clinical academics in the country is now shrunk to less than 3% of the workforce. So if we want our medical schools to deliver on their education and their research in the future, we're actually going to need some clinical academics. And while the number of NHS consultants has expanded by literally 70% in the last 10 years, the number of clinical academics has shrunk. And that's particularly so at the senior lecturer level. So most of those clinical academics are old and grey like me. And I think we've got a real problem there that we're going to have to address as a nation. And then finally, of course, we've got to, I keep on saying finally, which means I haven't come on all my sides, but we've got to train the trainers, and that's providing education for everybody. So in conclusion, the doctors of tomorrow will graduate from the School of Medicine. I think there's been a lot of negative press, there's been Chinese whispers, and there's been this assumption that we may not have a medical school. I do not think that is the case. I know we will have a medical school, and students will be coming in 25, 26, and will continue to graduate from Dundee. And we will continue, as I said, I firmly believe, to have great students and a great reputation, because I think the work we do here is outstanding. But we've got to change what we do. And so in addition to foundational knowledge, we're talking about lifelong learning, critical thinking, adaptability, generalist skills, digitally aware, soft skills, professionalism, leadership, et cetera, financially responsible. So these are big issues that we have to start students thinking about beyond just passing the MLA if they are going to be able to be contributing to the NHS in the future. A big challenge, but we're all part of that, and I think we all recognise the need to deliver it. So many thanks again to all of you on the call, because I know you will help with this programme itself, and I hope that's been helpful both in terms of an update about the finances, but also just a reminder of how good we actually are in the University of Dundee. So thanks for taking the time to listen to me. I realised I've talked a lot, and probably too quickly, but it'll be posted up online afterwards that you can look at as well. If I flip over now, I've got some chat lines on the calls. Okay, it's just about the meeting. So I don't know whether there is anybody who particularly wants to ask any questions after that. We've got a few minutes. I'm happy to take some. I can move that across to my screen. I can stop sharing and expand the scene. Andreas. I got a hand up. Does Andreas want to make it?
Yeah, sorry, I was muted. Thanks, Rory, for this very informative lecture and also the positive thinking. I have a comment and also a suggestion. As you know, I'm involved in medical technology for many years, and I found that the medical education still is lacking important basic background for a doctor. When they come into the clinic, for example, a surgeon has to operate with a robot. They have new electrosurgical equipment. IR, there are new devices, stents, heart valves, orthopedic, new materials, no implants. It's an endless list. And we had many years back in Germany an attempt to create a curriculum with 10 um, elements where basic things are taught. So patient monitoring, electrical safety, and also a bit of the quality management issue where a doctor has to be aware of devices that may not be labeled yet for use and so on and so far. Is there any idea to include this?
Sure, Andreas, I think you're right. Obviously, the tech world is changing all the time, and principally we're looking at the context of digital data at the moment. But I think you make good points. What I suggest you do is if you forward some of that information, particularly about what's happening in Germany, which I think you know well, to the MBCHB team, we can look and see what we can do with that space, particularly within that Dundee doctor element, which allows us a little bit more flexibility. Because you're right, the tech world changes just so quickly that I think there are aspects of technology, not just digital data, that you need to be aware of at least some of the pitfalls or know where to look to find out about those pitfalls while you engage in this technology. So yeah, go ahead, please.
Industry often makes claims, and if the doctor is uncertain what this claim might be, what the background is this device really so safe? There's a long history of false claims.
Absolutely, and I think even at a postgraduate level, I'm
that's
sure
why we have all these MDR and all these things. So I'm happy to provide some basic suggestion. Also, in view of our collaboration with engineering, we probably have a good proportion of engineers who could teach in that interims interfacing science area.
Thanks, Andreas. As I said, if you'd reach out to the undergraduate team, I'd actually suggest you reach out to the postgraduate team as well, because I can imagine in areas like, say, anesthetics or radiology or surgery, that type of information would be useful, and that's very much in the postgraduate space.
Okay, thank you very much.
Okay, folks. Well, no questions popping up there, and at the moment the comments are yeah. Thanks for the comments on the side, but no questions in there as such. Again, much to be proud of, and I continue to say that we have a very strong, very viable medical school. Continue to be here for a long, long time to come, and so. Again, congratulations to all of you, because we are here, of course, because of all of you and all the work that everybody does, both within the university and absolutely within the NHS. That's our great strength. So thanks again, folks, and I'll speak to you again soon, no doubt.